name is J.D. Buchert, and I'm really pleased to be here. I come to you from Parkland Hospital in Dallas, Texas. So these are the 3 research projects that I was very fortunate enough to do. At my hospital, they didn't have nurse-led research. It was really kind of disappointing when I went to this facility and found out that they didn't. So like many of you, I'm very hard-headed, and I decided to make sure it happened. So these are the 3 projects that I was able to complete, the first 3 in 175 years of my hospital's existence. So this is a very touched up picture, just to let you know. AI is amazing. So, but that's what my real hair color is. So these are your learning points on this right here. And these are kind of the questions that kind of led me onto this journey. So just to let everybody know, my journey started a few years ago where I had stage 4 cancer. So I really utilized aromatherapy for my own use. And it was so successful with me in my recovery and everything. I'm cancer-free, by the way. But in my recovery, thank you, that I wanted to make sure if we could benefit our patient population, but not only our patients, our co-workers, because nurses get stressed a little bit, right? Just a little bit. So I have no conflict of interest. And remember I said that they didn't have that nurse-led research in our facility, so obviously they didn't have a budget either. So I was able to do a university hospital collaboration grant. If you've not done that, please think about it. And now I get $45,000 a year earmarked to nursing research for our facility. So I want to tell you a little bit about my facility here. Parkland was first opened its doors in 1894, and it's one of the largest public hospitals in the country. So it's first certified level 1 trauma center in Texas, and the 2nd largest civilian burn center in the United States. Yes, I got burn nurses. I love it. I love it. So, but the other things, let's see if I can get this thing to scroll down. I'm learning this at the same time, so you got to forgive me. So the other aspects of this is Parkland is, as we built our new 2.1 million square foot, 1,000-bed hospital. It's not the old hospital that JFK passed away in. But we have built a new one, moved into it. It's phenomenal. We have about 90 procedure rooms now with our ambulatory surgical, our OR, and then our GI, cath lab, and IR labs. So with that being said, we are also a very green hospital. And every year we have done about 3.8 tons of waste that is saved every month. And then we are saving about, I think, 1 million gallons of water every month also. We have our own plant for our energy, and we're actually one of the top 50 greenest hospitals in the United States. And it's a big privilege to be able to be at such a large facility because we have 75 occupied properties. We have 13 clinics, and we have 20 also school-based clinics that we provide our county with, but we also do correctional health. We have 7,000 inmates that we provide healthcare to. Wanted to give you kind of a big overall picture. So on a typical day, we're seeing about 3,200 people in our primary care. Nearly 900 people are cared for, and 36 babies are born every day at Parkland. We see over 700 people in our emergency department every day. We are the busiest emergency department in the country. Last year, we did 26,000 surgeries. The reason I keep going on about this and the 5.6 million pathology procedures and the 12 million prescriptions that we filled, and if you that's 36 babies born every day, that ends up being about 13,000 babies a year. How many people live in a town about that size? I grew up in a town where there was 12 people in my graduation class. So I want to go over these again. So the way that aromatherapy works is it actually goes to the olfactory receptors, and it goes to your amygdala, and then that's your emotion response system in your brain. So that's it in a nutshell. So if we can think about grandma's baking in the holidays, or the smell of an ocean, which I do love, but there's nothing better to me than fresh baked bread. Those are the memories that I always remember from my family. The other things that are really great about this is that they can invoke historic responses. It takes you back, right? When you smell something, you guys remember when, and you can remember the smells. It can also work on receptors for the pain receptors. And that's why I was wanting to try to figure out, can this really work on us in multiple levels? So Code Purple was the first one that I did, and it was right in the midst of that pandemic arena. And so during that time, we were working in that person-to-person system, and it was very easy for us to develop emotional burdens during the COVID period, right? How many people ended up closing down most of their OR? All the elective procedures are closed down. Were you guys reassigned? Donning and doffing stations, things to that aspect. It was a very uncomfortable situation, wasn't it? I know some OR nurses that went to ICU. Very frightening. So for nurses specifically, the work stressors that have been identified in this risk category that have a negative impact on the well-being and the quality of our patient care. So I always like to say this: stress is a condition that occurs when the physical and the psychological borders of an organism are threatened. So let's think about that. During COVID, do you think that the physical and the psychological organism might have been a little stressed? So really wanted to see what we could do with this. So here is the purpose of this. During the COVID pandemic, we brought many challenges to the field of nursing. Bless you. Nurses are facing unprecedented patient acuities, burnout, fear, uncertainty, that continuously evolving workflow. However, we were also facing nurses shortages. How many people had a tremendous amount of travelers that all of a sudden showed up at your facilities? So therefore, that workplace or workforce related stress had become one of today's most serious occupational hazards. We're really fortunate that aromatherapy can be a non-invasive, inexpensive, convenient method of relief. I want to show you some of the successes that I had with this. So the nurses at our facility, we have about 43 to 4,600 nurses. And so they all volunteered. I had 26 nurses that became co-investigators and research of these projects. And it was really great because what you're doing is you're starting to inspire them that they have a voice that they can advocate. They can create change. That is the most specific, amazing thing that can happen when you get I call them baby nurses because I've been a nurse for about 38 years now. So, but when you get those young ones, thank you very much for people saying that I work in plastic surgery because I know I look young, so no, I'm joking. So, but on this, it was really exciting to be able to show them the power of their voice. So when we did this, we had the exclusion criteria if they had known allergies or sensitivities to aroma products. You know, a history of respiratory problems, asthma, allergies to fragrances, if they had a loss of sense of smell, at that time COVID, right? So at that time, I didn't know that the olfactory still worked. I thought if you lost your smell, it didn't work anymore. Now I know better. But also the sensitivity that they had, if our patients had the sensitivity to the fragrance, how did we handle that? So what we did is we would take that, we had a sticker, aromatherapy sticker that we placed on our scrubs. You could take that sticker off and put it on the door frame before you were servicing that or providing care to that patient. So we had ways around it, but we also had to think about our coworkers. What if they had sensitivities? We're very fortunate that they did not have that happen, but we had a game plan just in case. So we had like buckets with lids, and it was amazing what we were able to do if we needed to squash a scent really quick. So we did a survey-based questionnaire using a QR code. First time I've ever done a QR code thing, and it was amazing how easy it was. And this is the one thing that taught me that QR codes is the wave of our future. If you guys are not already using it, I'm pretty sure everybody already is, right? So, but we were able to do this QR code survey 4 hours after the initiation of the aromatherapy. So we asked specific questions, and we also were able to gather some data on their history, RN, LVN, gender, age, things to that aspect. But the descriptive statistics used for the means, median, and ranges with the paired t-test to compare that pre and post intervention. So we had a baseline of 326 people that volunteered for this. And then I found those 7 anesthesia people that aren't nurses, so I had to exclude them from the study because this was just for nurses. But I still let them have their patches. But I had to account for them, right? It's amazing in research, you have to account for every single thing. So we had those 7 that were excluded, which brought us down to 319. And of those who received, we called it code purple, the lavender patch, the intervention. I can't wait to tell you at the end what the success rate was on this. I almost gave it away. So of all this, how many people do you think were the first to step up? Kind of like this room, it was mostly women. So an overwhelming support of female staff seen at 91.2 compared to that 8.5% of male nurses. Interestingly enough, the age bracket that sought out stress reduction therapy was seen in those in the 30s, about 36%, and then followed by those in the 20s at 30%. This led to another question. Are nurses just coming into the nursing profession more open to our alternatives than the professional self-care than us veteran nurses? Kind of makes you ponder. So now let's take note of the nurses in that 10 to 20 year bracket on this and what their experience was. And they had, they had that higher stress score before the use of aromatherapy, and it showed that they had a higher reduction level also. So it got you to thinking, nurses with this level of experience are often carrying a heavier workload, which can include precepting, charging, leadership responsibilities. And when they're carrying that other load, they're also carrying that emotional load for their staff. Imagine carrying that emotional burden during COVID with your staff who are scared just as much as you are. So I really wanted to make sure that we did our frontline people, but also our leadership, because they're carrying quite a bit of stress also. Here is what our most common staff stressors were from those QR codes, that survey. And so the Code Purple Aromatherapy Project aimed to focus on the nursing experience's mental and emotional stressors. The most common found stressors were compassion fatigue, violence. We had a huge increase in workplace violence, and it seems like it continues to increase today. Time pressures, exposures to infectious disease, needle stick injuries, sleep deprivation. Also had role ambiguity with the conflicts, understaffing, and dealing with difficult, critical, ill patients, and death. So on this, note how close the comparables are with the staffing. Remember I said before we had that administrative leadership and then our frontline staff. Look how close those are in reduction of the staff. But also, we were all still bringing our personal stresses from home on this, because were they elevated also? I mean, how many people were having difficulty finding toilet paper or paper towels and things to that aspect? Remember those challenges? Or trying to find hand sanitizer. It was crazy. Those personal stressors became part of our day-to-day lives too. And how were we releasing our stress? Our norms were taken away from us. So this is the aspect of this first project that I thought. These results warranted recommendations to further disseminate aromatherapy to nurses and all staff working in high stress areas in the hospital setting. And the investigators, myself and my team, have received the request that we add peppermint to this, because they do have a peppermint and lavender patch that actually kind of increases your energy level too. So I might have a big mouth and say, hey, maybe we should do this, So and I shared some of my secrets. But also, the perioperative implications of this project have shown that the motivation of self-care can increase the likeliness of staff retention and a happier staff. So we did see an increase in our staff retention, which was incredible because if we're replacing a nurse in our operating rooms, it's running about $55,000 for each nurse that we're replacing. So if we can hold on and maintain that nursing, it's going to be really cost saving for our hospital. All right, here's the big news right here. So on these self-reports, we found out that there was a nearly 40% reduction in stress. The good thing is that we had 83.7 said that they had a positive experience with aromatherapy, and 91% said that they would recommend this. They wanted to keep this. Very fortunate that our executives heard this at my facility, and this is available to all staff now. We have 15,000 employees that have access to aromatherapy now, but it also goes to our patient population. So here's the first patient project that we did, and it was the effectiveness of aromatherapy in an urban safety net hospital for pain and anxiety. So what we did on this in 2018, the Joint Commission mandated that we have a required solutions for reducing pain and discomfort in our patients, but we also had to reduce that opioid usage. You guys remember that, where the opioids are becoming, and it's so true. This is the second project that I did after I went through my surgery, my chemotherapy, and found out that the reduction in my opioid usage was dramatic. So aromatherapy for pain and anxiety has evolved a simple, repeatable, low-cost intervention. Again, I always say low cost because I want to make sure that that really sticks with everybody. But this is something that doesn't need a prescription from a provider. And again, it's a nurse-led action, which is a really great thing. So the benefits also included improved patient satisfaction scores. So let's go forward and see how this goes. So right here, you can see where this aromatherapy sticker would be placed. And on this, I don't need to read this to you, but there was two reasons that we did this. Remember I said my burn nurses back there? The secondary focus on this was that we were actually seeing that this could be utilized in our burn patients because we have what we call the tank, but we're going in there and we're doing wound care on the floor. We call the room the tank. And so when we are scrubbing those burns, it's a really intense amount of pain. And they are at a level where they can no longer have any more pain medication. So they're enduring these pains. So we are trying to psychologically have them focus on something. We had music in there. We had colors in there, but now we introduced aromatherapy, and it really helped to give a good focus on this. And so we ended up presenting at the Burn Conference a couple years ago, last year, excuse me. And the success was so tremendous that we have, I know, 16 burn centers that are now utilizing aromatherapy. So on this one, what I did is that we had 40 exclusions on this. I was very specific on this because with our patient population, we really have to keep a focus on the safety of our patients, right? So if they did not meet the criteria, such as they had to have an admit pain score of 7 or higher after their surgical procedure, because what this did, this procedure followed that patient to the inpatient floor for 72 hours. And so I did a comparable from the year prior, same season, so there would be no bias on the seasons, but the same patient population. I did this on 4 floors, burns being one of them, but we did it for our trauma floor, our trauma general surgical floor. We did it on our plastics floor and our orthopedics floor. So with those 4 floors, we had 184. Because we were still in that season of COVID, a lot of our elective procedures were still not available. So we had to really break down and to have the same patient population with the same procedures the year prior. That's why this number to me seems a little low, because we do so many surgeries. But I was very specific in making sure that comparable data was there. So of those exclusions, we had 24 that didn't meet that 7 or above. We had 7 that were consented improperly. We had 1 that actually got through and had a history of asthma. We stopped it before the patch was put on. We had 1 that withdrew. We had a couple that their surgeries are canceled. And then we also had some transfers to higher level of care, ICU. Once they left that floor, that project stopped. So that's what those 40 numbers are. All right, so again, we use lavender sandalwood on this one. And with this, it's the same. It promoted relaxation and comfort and sleep. What's one of the best things to reduce your anxiety? Sleep. How many people get enough sleep? I want to see if anybody raises their hands, because I was going to come challenge you. But after the introduction of this, and we consented the patient before they even had a surgical procedure, and then we followed them up to the floor. So the aromatherapy was changed every 12 hours. The reason, even though the aromatherapy tab worked for 24 hours, what we did is we wanted to make sure that it was regimented into that medication administration. So there are certain medications every 12 hours that are given. So that's when we did that. It was usually a 12-hour shift, so the nurse was responsible for it for one time in their shift. That's why we did it every 12 hours instead of 24 hours. And the great thing about it is, if the gown gets soiled or something, the aromatherapy tab can come off and get put back on to the new gown. So the adhesive on the back of this never comes in contact with the skin, only with the gown. And if they were at a point where they couldn't have a gown, we put it on the headboard right above them. All right, so we followed these patients for 3 days. We found some really cool stuff. So data slides. This is all the data collection, sample sizes, all that. Any statisticians in the house? Oh, she was combing her hair, and I swear to God, she was going to raise her hand. I was like, oh, she's going to challenge me. So I'm very fortunate. I had a statistician that's on our staff. So we were very fortunate that he helped me with this. This is the means, the median, the bell curve, all that other information that is really interesting to each and every one of you, I'm sure. But I want to make sure it's there so you guys can see it. Because when these slides are shared, and I hope that they are, that way you guys can see where we come from, how we walk through it. So let's look at the demographics on this. So the demographics are very, as we are in Texas, and you will hear me say you all this weekend, and forgive me if I offend anybody, I am from the South. And so we have a high patient population, being a community safety net hospital of a Hispanic population. So 50% of our patients in this program, this project, were Hispanic. The one thing I didn't tell you is that in our hospital, we have a translation service that translates about 1.7 million people every year. And we speak 181 languages in our hospital. Gender, I was very surprised by this. For some reason, in the OR where I was at, I always saw more female patients. So to see the more male patients in these projects was really cool. Orthopedics was one of our biggest suppliers of these projects. And then the age. The age ranged in gamut, but I was really surprised to see that the biggest majority of our patient population was in their 50s. All right, so the next slide is going to be my favorite slide. So this is our control group. This is the group that's 1 year before this project. So on admission to the floor, their average pain score was 8.54. 24 hours, you see the 6.18. Follow that is 5.74, and then after that completion of the 72 hours, that was their final score of 5.67. You guys interested to see what aromatherapy does? had an average, hey Barbara, we had an average score of 8.33 on admission. But look at this 24 hours later, 4.11, 4.01, 4.02, and it continues to go down. It's kind of cool, isn't it? So think about the opioid savings that we're having on this. Also think about the rest that our patients are getting. Also think about the decline in aggression. Happy patient, right? So let's do them side by side. So you can see that the white knight there on the bottom line and a side-by-side comparison with the use of a $2 aromatherapy tab that you can put on a patient gown. So let's another side-by-side. Let's see what these are. So in our admit score, we only had a 2% difference from our year before and our patient population that was in our study. But look how drastic these other ones are. 33, 30, 25, and even afterwards, after the project, it was still a 37% difference in pain scores. So, and as I said, the nursing staff noted that these patients participating in the project actually slept better, and they had less aggression and agitation compared to those who did not participate. So there was a whole nother side-by-side comparison. And my new role at the facility is I'm integrating the workplace violence prevention into our hospital. And I have lobbied it in our state that passed a law for workplace violence protection against all healthcare workers. It's now a felony in our state. And I have been going to Washington, D.C. and lobbying for the SAVE Act. So how are we going to do with our patient scores? So we surveyed these patients afterwards, and they actually had a choice between a QR code or a paper, and given the choice. But it also came in multiple languages. And then for those patients that spoke Farsi, I didn't even know what that language was until this project, we had translators that walked them through this to make sure that they had a full understanding. So how much did aromatherapy help your pain? And this is all 4 of the questions that they could have answered. A lot, some, little, or none at all. So if you see this right here, we're sitting at about 50%. It was either a lot or some. How much did this aromatherapy help you to feel comfortable? Remember, these are surgical patients that just came out of the OR. How comfortable were you if you've ever had a surgical procedure the first 72 hours? It's really difficult to get comfortable, isn't it? Oh my gosh. And then try to get up to go to the restroom. My goodness, it's a whole other story. But a lot. So I like to say this, almost 85% was effective in a positive manner when it came to that. And then last is how much did the aromatherapy help you relax? And again, we're sitting at about 85%. So these are big numbers. Do you think that those might have reflected on our patient satisfaction scores? All right, what about this? Oh, now it gets really small. So these are patients, these questions are directly asked to the patients too. How much did better or worse did the aromatherapy make you feel? Again, we're seeing close to 90% have them a lot better or a little better. And then our second one is how much would you want your friends and family to do aromatherapy? Look at that score, almost 100%. Then it goes to the how much did you feel like our hospital cared for them at that moment when we gave them this aromatherapy? A lot, almost 60% at a lot, some for 34%. And then how much would you want aromatherapy if you came back to the hospital? 65% said they definitely want it again. So we're now utilizing this in our surgical procedures, but we're also, I can't wait to share with you what we're doing for our next project that we're actually utilizing some aromatherapy too. So in this one, we used the orange peppermint aromatherapy. On post-operative, everybody knows about the PONV, right? How many people know about the post-procedure, MAC procedures? Do you guys ever give aromatherapy for our MAC procedures, our GI procedures, those monitored under anesthesia when they're doing podiatry or something to that aspect? You know, about 12 to 17% of all of those patients also have nausea and vomiting associated with their anesthetic. So this also ties into that 2018 Joint Commission standard that they came out with, that requirement. So it wasn't only opioids, it was other medications too, antiemetics being one of them. Why? Because antiemetics can actually cause adverse effects to people on antipsychotics, people in pain medications, but also people that might be taking hormones. I was taking hormones during my cancer treatment. And all I could say is every time I would pop a fan, I kept saying I'm not warm enough because I couldn't figure out the hot flash thing. Guys, we are so lucky. So on this, here's the whole purpose and thing, but you know, there was current research on PONV. We all have heard about it. We all kind of know that there is benefit for it. And we all know that the citrus is a big aspect of that. But the one thing I couldn't find is what can we do for our patients that are going through GI procedures or those podiatry procedures, those low, I call them the MAC procedures, those monitored under anesthesia procedures, right? Where they're not completely intubated, but we want to make sure that they don't experience that pain. So we're making them very comfortable. Thank you, propofol. So we found out that this evidence can cause side effects that interact with these pain medications, antipsychotics, and chemotherapy agents. I forgot to mention that one. But also, we already know that the side effects for nausea and vomiting, right? So dehiscence, so increased stay time in PACU. How about that? What's the cost of that? And there's uncomfortable moments. So let's go through this. This was a 3-month study that we did, and then we ended up having 334 participants in this project. We excluded 37, and those 37 were excluded because they either bypassed the PACU and went directly to the floor or the ICU setting. We also had patients that actually took their original consent home. So I could not use their information because I'd have to make sure that it's a documented event. We had 3 people that their surgeries were canceled. We had 4 people that actually refused when they got back to PACU. Have we all seen a little bit of personality change sometimes when they go to that PACU and they're coming out of their anesthesia? It's understandable. We didn't fight it. We also had 1 that got through and we found out that they had a citrus allergy. Just like the asthma before, we stopped it before it touched the patient. We had 1 patient that just left AMA out of our PACU. I was like, what the heck? So I'm pretty sure those words are a little bit more patchy. And then we had 3 patients that the PACU nurse forgot to put the patch on them. And it happens, especially when you're very busy. And so the benefit of this is it's pretty cool. So this study focused on the patients that were going under general anesthesia, and the study followed the patient population for the first 8-hour period. We know that all of our patients that are going through surgical procedures are not necessarily going to be in that recovery area for 8 hours, but we wanted this to have that available for them to have that patch on them all the way through. As we know that these aromatherapy patches that we gave out lasted for quite a while, we wanted to make sure that they understood that too. And it's like, hey, if you're already ready to go home, what we're going to do is we're going to put that patch on your shirt or whatever you're wearing to go home in. So that way you can still have the benefit of this. So we wanted to make sure that they still had the benefits. So the demographics and the clinical factors were also collected to avoid that bias at the same time, same procedures, same time of year, same procedures, and so forth. So if I was in the main OR, I have comparable for the main OR for the same procedures, and the ambulatory surgical setting, and then our GI settings. So we kept those, and we already know that these are pharmacological solutions, and these are adjuvants or complements, right? So this is, again, I'm going to say it, this is a nurse-led opportunity. So this is something that does not need a prescription. This is Steve Brown again. He wrote this slide out for me. I love Steve Brown. He's amazing. He has 3 kids in college right now. I don't know how he does it. I had one, and I felt like I needed to sell my house. So the one great thing about conducting this is you have people like Steve Brown on your team. He has been instrumental in helping us with all the data. And I've been very fortunate since I started doing research, and I've done 7 research projects at my facility. And Steve Brown, I pretty much have signed him to a lifelong contract with Parkland, and he's unable to move now. So, and he gets paid very well. So the message of this is the patient population, as I already said, we kept it up to 8 hours, but you know what? If they weren't in the PACU for 8 hours, that's fine. We still did that survey on them before they left. We did the informed consent in the pre-procedure area, and we explained all the benefits, and we explained everything that was involved with it. And then we put the aromatherapy either on the upper part of the patient gown, which I showed you a picture of earlier, and then we collected this demographic and survey data. So from that, we had 336 patients that enrolled. We had, and I already explained to you what our bypasses were. So with that, we had 38 patients that received the light sedation. This is that information that I really wanted to see if we had benefit with that patient population. I can't wait to show you the outcomes. But we also had patients in 3 different surgical settings. So this was kind of a multi-site experiment within our own facility, which is really cool too, because it really brought, again, those nurses together to say, hey, what are you seeing? And they were creating conversations within our own organization. And it really has paid benefit. They started a journal club. I think that's pretty cool. So here's our demographic. If you can really notice that age bracket, they're all very, very similar. Gender, more females were inclined to say yes to this than men. And then we broke it down by race and ethnic group. And again, I'm going to remind you guys, I am from Texas, and we have a large Hispanic population that we service at our hospital, being a safety net community hospital. So here's where it came down. The perceived effectiveness. This is for all of the patients for both projects, right? For all of the areas for the light sedation and the full intubation. So patients reported nausea and vomiting. We had 64 that did not report anything or mild at 18%. Our patients report results on this was they had lessened nausea, they felt relaxed, they felt like the hospital cared. That was the big things that I walked away from that with. The next one was pretty cool too though. Did it improve your experience? So I'm always thinking about, I went to leadership. I know I don't bring a torch at me or anything. I went to leadership, and one of the things that's always we get browbeat into now is those patient satisfaction scores, because that's always our return on investment, right? How are we going to make revenue for our hospital? Patient satisfaction scores, those are the things that get us paid. I didn't realize that until I went. I was a military nurse, retired. I was a combat nurse, then I was a surgical nurse in the military. And then I retired, and I've only worked at one civilian hospital. So I didn't realize the difference between a military hospital and a civilian hospital. Money, goodness. So it improved their experience. We had 82% said that it improved their experience. The great thing that was coming back on these patient satisfaction reports, though, is they were remembering the nurses' names. How many times have you heard someone say, Mary Lou put this patch on me and it made me feel good all the way home? You know, thanks to that aspect. It was really great to have that connection with our patients, because I come from a time, and I'm sure you guys do too, we meet a patient and 5 to 10 minutes later, they are asleep. So we have a window of 5 minutes to create a trust factor, right? Or would you be interested in using this again? 86% said, heck yes, I'd like to use this again. So for all of our patients, this is what we did. And I should have actually broken this down into like a percentage variable, but these are the 4 antiemetics that we utilize at our facility. And so, and this is, I shouldn't have broken down into the total, but I wanted to show you guys the total numbers. I think that's going to be a very important thing on this. So with the use of aromatherapy, you're seeing this. But look at this. So this is what they're perceived with. 13.6 was that light sedation, and then we had 86% that was at full. So this is their scores afterwards. That's all that they were utilizing this for. So they may have gotten that first dose, but that second dose was only 1.37 for all the participants that received a second dose or a second antiemetic. And you know, sometimes we are so trained when we come out of the OR, if you're a CRNA or if you're an anesthesiologist, that you automatically just push the antiemetic before you even take them to PACU, because they're not used to this kind of therapy. So those numbers have actually started to drop where we're not automatically pushing an antiemetic now, because they're already going to be able to get that antiemetic into them through the IV, right? Fast response. So now we are seeing if we can utilize this without having that first dose before they leave the OR, and it's working. So these are the numbers. I'm pretty excited. I keep wanting to hit the computer screen. And again, patient satisfaction. Patients are saying 70% of them for our monitored anesthesia. This is beforehand, right? So monitored anesthesia, patients reported nausea and vomiting after aromatherapy. 20 patients reported the results of this, that they felt relaxed, lessened the nausea, hospital care. So if they were still receiving that first dose of antiemetic, but were they receiving the second? Here's again the aromatherapy experience, preview experience today. 87, almost 88% said yes, and 92.5 said that they'd want to use aromatherapy again. That's kind of a really great opportunity to say, hey, do you want to use this or not? You know, we're going to give it up to you. It's your decision. So how many, I just want some numbers, people to yell at me. I like to be yelled at. So how many people think, what do you think the number would be for a second dose of antiemetics for these monitored anesthesia? Remember I said 12 to 17% is the average nausea and vomiting experienced by people going under these procedures for these light sedation. Anybody care to take a guess? 5%. That would be a great number, wouldn't it? How about 0 patients? Our second dose of antiemetic was 0 on these light sedation cases. And it really made a huge difference. Really, if you know the song, I Saw the Light, this was the definition of that. So if we do our comparables, this is everybody on that first dose, or the second dose, and before the first, this is our control group, excuse me. So this is the people that were in the first year that were not going through aromatherapy. This is our comparable group. So we did see that we did have a second dose of antiemetic in those groups. Now let's go to our general anesthesia. And again, we're going to do the same thing. The patient reported nausea and vomiting. We had 63.5 that said no, because you know, there are those factors that come with it. Female, if you're not a smoker, you know, things to that aspect, those can increase. If you have motion sickness, those can increase your opportunities for nausea and vomiting. And so with this, it's not everybody's going to get these side effects. But we're also seeing that the patient reported these results. Again, lessened in the nausea, they felt more relaxed, and they felt like the hospital cared. General, this is our second dose of antiemetics that was given. 74.5% did not receive a second dose of antiemetics. Do you guys remember those numbers I was telling you about what is it? We have some patient populations that will receive 4 and 5 doses of antiemetics, right? Afterwards. It's sometimes nausea and vomiting is really hard to shake. I remember I drank some Snops when I was skiing when I was a child. Huge mistake, but it took me about 4 days to figure out that that was something I'll never do again, right? And it was associated with nausea and vomiting. The great thing about that is that we were able to reduce the secondary dose of antiemetics utilizing this. Remember I was telling you about the cost, the minimal cost of aromatherapy for our patients? So how about this? So our control group had an average stay time in the PACU of 148.8 minutes. With aromatherapy, our research group had an average stay time of 111 minutes, 111.75 minutes. Do you guys think that there's some cost saving association with that? It's about what, 30 minutes? You think you might be able to get more surgical procedures in, quicker turnover? Get a break. Oh my God. How many people actually get a 30-minute lunch break? I just want to know because I want to know what your secret is. So I still do PRN in an ortho clinic, every once in a while, just to keep my skills sharp. And I still try to figure out how do we stand all day? Because I mean, telling you, our feet kill us. And thank you, Good Feet Store. But how do we get the proper nutrition? And how do we not have consistent bladder problems with having to go to the restroom a lot, right? Because you have to wait and get relief and all that. So we all have those pains, and I'm not going to say that aromatherapy can cure those, but it sure helped me. So here's my summary, and I probably went through this a little bit quicker than I should have because I was very excited when I came into the room after being up since 5 o'clock and having all my obstacles come through. But this is a really great alternative therapy that can benefit the well-being of our healthcare workers, but also our patients. So these projects have shown the benefit of aromatherapy, and it is an alternative or a complement to our traditional care. So if we start to think about that integration of Eastern and Western philosophies of medicine, this is one of those things that we're talking about. But it's also saved my hospital $2.6 million a year. How's that sound? Numbers talk. Walt Disney, one of my favorite guys. I already said I'm a little goofy. The way we get started on something, we quit talking about and let's start working on it. And then I just want to say thank you. Please, if there's any questions, I would love to hear them.